There have been a lot of times when we start programs, we don't finish them. We can't afford them. What is the point? Programs should be based on needs, and needs that we think, oh, this one, this is what the people need. This is what will help. And this is what we can afford. So definitely, we should be doing things that are in line with our economies of scale and our level of social development without being all over the place, because then we'll be nowhere. I think we can do better than that.
You're listening to Patterns and Meaning, a podcast by Seed Global Health. We find meaning in patterns, connect history to the present, and illuminate the way forward in global health. I am your host, Edem Tokunu. Our guest today is Margaret Phiri. Margaret is a nurse and midwife with an illustrious career that spans every corner of the African continent. She has a master's in nursing education and leadership from Columbia University's Teachers College. She also has a postgraduate diploma in community health from the Medical University of Southern Africa. Margaret is currently the Nursing and Midwifery Advisor for Seed Global Health Malawi and a member of the World Health Organization's high-level consultative group on the health workforce. She previously served as the Regional Advisor for Nursing and Midwifery for the WHO's Africa region, Human Resources Health Advisor for Swaziland, Regional Capacity Building Coordinator for East Central and Southern Africa's Health Community, and served in the same role for the East Central and Southern Africa College of Nursing in the SADC region. She was the Quality Assurance Director and Senior Lecturer in Education and Leadership for University of Malawi's Kamuzu College of Nursing and the Maternal and Child Health Advisor for WHO in Sierra Leone during the Ebola recovery and transition period. I spoke to Margaret about the critical gaps in health policy across African countries, actionable steps that we can take to address these gaps and ensure that policies are people-centered, responsive, and effective, and some of the lessons she's learned along her journey that can aid in our collective efforts to decolonize global health. Welcome to Patterns and Meaning, Margaret. It's good to have you on the show today.
Thank you very much indeed, Adam.
You've worked in several roles in the development of healthcare policy across Africa, and one of those is your most recent appointment to WHO's high-level consultants group on the health workforce, where you are advising on policy and planning for the health workforce across the continent. So in your experience, what are the critical gaps that you have seen in health policy across African countries?
That policy is very key. In everything that you do, especially in terms of programs and really giving strategic direction for the health program for the countries. Now, I'll make specific reference to the experience that I have had with the WHO, with all the countries in the African region, the member states. And I would comfortably say that most, if not all of them, have got national health and human resource policies and other priority program intervention policies. However, the challenge that has always been there is, one, the development processes of those policies. Most of the time, countries use a top-down approach, top-bottom approach, leaving out the implementers to be part of the team being on the table during the time of development process. That is one of the biggest snags. Dissemination strategies, too, of such policies are normally not really the best to use. And especially if users of those policies are not even given enough information about what those policies are and how best they can be utilized to improve service delivery. So you will find that, and they're not effectively being implemented. So the key thing here is involvement of the users, of the implementers during the development process. Don't use them at the end, because then they don't even understand them, they don't even value them as to why it's important to have policy direction on the programs that they're managing. So maybe just to add on to that, one of the things, of course, is that we also do have some knowledge gap in terms of policy development process. So one of the key things that WHO does, and is very good at that, is giving guidelines to countries, building capacities of the different people that are involved in policy development, and policy use. So normally when we support countries, those are the guidelines that we use to help countries to at least be sure that whatever they're developing, they follow the process, and that the people that are supposed to be involved are involved at the right time, especially at the beginning of the process itself. And then finally, maybe also just to say that even when policy documents have been disseminated, there's very little support for implementation to give to those who are now supposed to be using them. You see, you can't use something unless you've been given the support. Support maybe in terms of how can they use them in their day-to-day planning, support also financially on how to mobilize people to come together and really understand the issues about those policies. So that support most of the time is really lacking, I should say.
So not involving implementers right from the development of the policy process, from brainstorming to listing out how it's going to be carried out and all those things. They are not being involved. And after that, when it comes to implementation, they don't have the support that they need for this. So in what ways do you think these gaps are a result of our colonial history or influenced by power dynamics at play in global health? We want to get to the genesis of this kind of process of policy development where implementers are left out. Is it connected to colonial history in any way?
The dynamics at play in global health as a result of these gaps, yes, it is connected to the decolonization aspect, very much so, in the sense that because policies are not effectively implemented, be it those policies that have been architected by the nationals based on their needs assessment or whatever, or the ones that have been developed through the guidance of the foreign policy or donor support policies. The point is that change is slow to come, yes, because those policies are not really implemented. Countries keep on going back and forth on similar issues that they could have moved, instead of celebrating the achievements that they have made right from the beginning when such policies were initiated and implemented or developed and disseminated with the aim of implementing them. So that back and forth has also led to the donor fatigue in terms of funding the same thing over and over. And for them, it's like they're not seeing the result. They're not seeing the differences that they would want to see as a result of those policy directions. So it has also made the donors to think that maybe we're not really serious as countries, because we need to be making progress. We need to be making change. We need to be at a different point from the way we started. And then the other influence related to that is that in an attempt to make a difference, and realizing that these changes, these policies are not maybe well supported to be implemented, donors have opted to bring in their own agenda and policies and support mechanisms that would actually see to it that there would be siloed projects, some kind of policy direction in their own many ways to make sure that something is done. And that in itself, again, has not really had really comprehensive desired results or outcomes, because they have been really a one-time thing that once they are done, maybe that's the end of it. And most of the times also they have not really been well phased into the broader aspects of the country agenda. They come in as isolated cases, and that in itself has not really made much of a difference in what we expect to have. So the other point maybe which I would want to make here is that global health can only change unless us as countries which were colonized take the lead and chart our own destiny. Let's be clear. Let's have commitment. Let's plan using the available resources to make sure that these initiatives or these policies we have developed can be sustained and make a difference into our people's lives.
Where do we start charting our own path from?
I think what is key is really an appreciation of what problems do we have that need to be solved. What methods, strategies can we use to do that, using, by and large, our own local resources, our own local people, our own whatever we can harvest to put together to move that agenda forward. Some of the things that we can do, which might actually be actionable, is putting our communities on the table during the planning processes. Let us hear from them. After all, we are there to change their lives. So they cannot be passive recipients of the changes we want to see in their lives. They have to be active members. So our governments should really be working very hard in terms of architecting or putting in place mechanisms that will involve the communities to bring in their own ideas, get their thoughts on what they think their needs are and how best they think those needs can be addressed. Secondly, I think I said it when I was touching at the top, was that we still have to continue with the bottom-up approach, that is, start with the community. And not only that, once the policies have been developed and we want them to be implemented, as I said earlier, let's then support our communities. Let's give them the know-how, the things they can use to make sure that the changes that are desired are actually achieved. This could be in way of knowledge giving, awareness raising, and then, there are a lot of small projects that really aim at empowering the communities to themselves to say, how do you want to see this change to be done here? Who do you think are the important people that can be involved? So I think if we do that, we might actually make a difference. In addition to that, I think our countries need also to be supported when they're developing their national development agenda. That these agendas should be very clear, with clear mechanisms of how they will engage the donors who are our supporters. So that donors are not coming to take over, but that we maintain the leadership and ask for the appropriate support that we would want to have. And maybe finally, I think all of us need to be empowered as citizens. Let us be the change agents in our own space. What is it that you can do without waiting for Adam, who is on the other side? It's always important, at least have the interest to say, with this, maybe this is what I can do. And I think that level of empowerment at individual level is very, very critical. One of the challenges, of course, that we have seen that maybe emanates from this colonization is that most of our communities are very illiterate. They haven't been to school, most of them. So their knowledge of understanding things is limited. So you need enough time to be with them and to be together to make these changes. For their own citizens, yes, they're there for us. And then for us being there, we need to see that commitment of driving the changes they want to see in their own people. It's not for themselves, it's for us. And we need to change. And I think if that can really be embraced, like it is being embraced, it's not all countries in Africa that are not embracing that. Where that is strongly embraced, there are changes that you can see. And even supporters or the partners, they think twice before they go there, even with their own agendas. But most of the time, they take advantage of where thinking is low and people are kind of selfish. They want to look at their own personal needs. That has to change. So we're asking our leaders to really, really be accountable for their actions.
Awesome. This accountability topic came up when we had the podcast conversation with Angela Nguku, who has also been a panelist on some of the webinars that have been organized on this topic of decolonizing global health. One question I asked was, do you know any examples of countries or organizations that are already doing pretty well in holding governments accountable?
Definitely, there are quite a number of countries. I would cite a few. Maybe I would give an example of countries like Botswana. Yes. I would give an example then, I don't know about now, countries like Namibia, your country, Ghana, in those days, where really governments are being held accountable and responsible. But one of the factors we have seen that makes our leaders lose that is the economies of scale. and the level of social development of that country. If a country is very poor, like my country here, sometimes we have challenges. We really become donor dependent, even when maybe it's not necessary to be donor dependent. But because we have been in that for too long, and you say, we can't do this, we can't do this, we can't do this. Then leaders, each time they come in, it's like a norm for them to do that. However, things are changing. There are quite a number of human rights development groups who are up in arms, really making the governments to work on their toes. We have one in Malawi here, and I think it was one of the groups that really championed this change of our election results. We go back and forth, and then the opposition win. So yes, it can be done, and there are countries where these things are actually done better.
I want to switch gears right now to looking at nurses and midwives. It's estimated that there are over 20 million nurses and midwives globally. How can we bolster their leadership and mobilize them to strengthen policies and health systems?
As you have rightly put it, 20 million is really a big figure, and maybe one of the high among the health care providers or the health workforce. And nurses are really at the center of any healthcare delivery system in the world. And most of the time it has been alluded to as them being the backbone of our health systems. Therefore, I think we can bolster their leadership and mobilize them by preparing them for this strategic role of being leaders. They have to be able to lead. They have to have the knowledge of the know-how. It is not just automatic. It is not. So they need to empower it. And I think if they can be empowered, and as I said earlier, this is the backbone, they're really at the center of any healthcare delivery system, 24 hours a day, 7 days a week, and name it. They have the opportunity to influence change within the healthcare system. And then secondly, they cannot lead if they're not prepared. That's my bottom line. So how is our education system? Are we prepared to lead? Sometimes yes, sometimes not. I've been a teacher for a long time, and we look at our curriculums that are actually maybe foreign-based. I mean, like in Malawi, we have a lot of people who are prepared through training programs in America, in UK, that some of these borrowed ideologies don't fit into our system. And we leave out a lot of critical things that can make us be better nurses and midwives. So my bottom line there is that for these people to critically lead and be strategic leaders, they need to be that. They have to have that integrity and ability to do so. And maybe one way of ensuring that is to really constantly keep on training and retraining them through CPDs, this continuous development program, mentorship, exchange programs, learning best lessons from other countries. Sometimes you do better if you see that other people are doing better than yourself. So if those mechanisms can be in place and implemented, much better. And above all, the government too should create a conducive environment for them to work. They should be recognized, not just the nurses, but all the health workers. Look at the epidemic that is happening now, the pandemic or coronavirus. If you can't recognize your workers, you're actually putting the nation at risk. So unless nurses and other health professionals are recognized as the gatekeepers of the people's health, of the nation's productivity, then it's going to be a big challenge. So government should support the nurses, put in place policies that would allow them to be engaged on policy development forums and really be the advocates of change, because they're the ones who are with the patients 24 hours, and give them that support. And that's my message. And also, nurses themselves, we should not just sit back and say, we're backbone and whatever. If we are true to ourselves to say we are the backbone, then we need to move an extra mile to make sure that we don't break the system. We don't break our backbone aspect, should not break the system, but we should be in the forefront and advocate for things that would make a difference. Have a commitment, true to ourselves, be professionals as we have been taught and led to practice our professionalism. Be knowledgeable people. Reach out, agree to work with other colleagues. We are not the only one. We are not the only players. Health is dynamic, and no single professional group can claim that they're the only ones that can make a difference. The answer is no. We are all equally important. And I think person who is really important is the client himself or her. So us as nurses, if we have to really make a difference in the healthcare delivery system, we should put up our socks and be ready to make a difference, make a sacrifice, and say, we're going to do it. We're going to make it happen.
That's a perfect segue to my next question, which is, let's imagine that you, Margaret, you have all the resources and support at your disposal. What are 3 key policies that you would put in place across African countries to ensure that nurses and midwives are equipped to do their jobs and that there is equitable access to high-quality care?
Just a few examples, the 3 ones that I've put down just for us to share is that we really have to have policies that are going to strengthen the education, practice, and regulatory systems of nurses and midwives. They have to have the appropriate education, properly regulated, for them to deliver and to be what we expect them to do. So education is key. If you're not educated, you can't claim that you can be a better practitioner because you wouldn't. And regulation safeguards or protects the public. And it has to put in place mechanisms that will make sure that these members of theirs, the nurses and midwives, are well educated, conform to standards that they have developed, and that the disciplinary measures that are put in place, that in the event that they breach and violate the ethical code, the standards that they're put in place, then they have to account for that. Second one, again, leading to creation of a conducive environment, including political commitment to support delivery of quality nursing and midwifery services. You see, most of the time, the nurses who are very dedicated need to do something, but they don't have the resources to use in the environment. You can't do it if you don't have nothing to do. Most of the time, we've even developed this theory for ourselves that making the best with what you have. But I think government has a responsibility that we need tools to use to provide that quality care, and they need to give us that support to do so. So creation of a supportive environment will be very critical. And lastly, really to look at policies that empower nurses as being strong advocates for change. I think I said that earlier on. Get them engaged, hear their voices, give them a chance to do something and support them. And then the nurses too, say so. Use our own forums that we have to make your voices heard that, you know what, we want to help. So we need such kind of policies that empower the nurses to do their best, nurses and midwives, I should say, to do their best to strengthen the health system.
When it comes to making this change, policy is just one aspect of the many other factors we need to actually make change. You have mentioned a lot of the other factors during this conversation, which is curriculum development, program design, and even our funding models. So what does a fully decolonized global health system look like to you?
If we have to have a fully decolonized global health systems, I think for me, first and foremost, is that let us be the change that we want to see. And I like Indira Gandhi's quote, no blame game. Let's do something. Secondly, a fully decolonized global health system means that there's total emancipation from donor influence, economically as well as foreign power dynamics. Because sometimes, you see, we get confused by imported ideologies. We may have something good to do, but then because we don't have the financial muscle, because we can't argue economically, then we get distracted. But I think we can do it if we really believe in ourselves and put our resources together to say, this we can do and we have to do it. Countries like my countries, which were previously colonized, I think we should take charge of our own destiny of our nations. It has been a long time. You know, this colonization happened a long time ago, and we're still talking about it again today. the influences that the left are still lingering amongst us, and we're still being influenced by those influences that the left. The point is, how then should citizens of the nation be empowered? I really appreciate the fact that, you know what, we need to get out of this. We need to be clear about our agenda, transparent, talk freely that, yes, we've got problems and we don't have the resources. Then we can be helped. In relation to that, we need to change our education systems, which are very much linked to the colonial days. We need to change the way we practice. We need to change the funding models that we have. You see, we have to look at things. Can we afford this? There have been a lot of times when we start programs, we don't finish them. We can't afford them. What is the point? Programs should be based on needs, and needs that we think, this one, this is what the people need. This is what will help. And this is what we can afford. So definitely, we should be doing things that are in line with our economies of scale and our level of social development, without being all over the place, because then we'll be nowhere. And I think we can do better than that. So those would be some of the suggestions I've made.
Finally, what are some of the lessons that you, Margaret, can share from your experience that can aid in our collective efforts to decolonize global health?
I think one thing which I'm very sure about is commitment to the cause. We have to decolonize global health. If we truly believe in it, we'll do it. So it's about you and it's about me to do something. It's about Adrian, it's about Margaret to do something. And then collectively, let's put our ideas to say, how best do we do this? And can we do it? And that leads to my second point, that I've always believed that together we can and we will. You see, there's no one who is an expert in everything and will not have everything all the time to do everything that we want. But if we put our thoughts together, we take a collective action, I think we can make a difference. And the other point is that change takes time. It cannot happen in a day. It's a process. It requires sacrifice. It requires commitment. So we should not give up to say, this is not changing. We started yesterday, up to today, it hasn't. No. It will require some taking, and we should be patient as long as we still maintain our determination. And then really reach out to those who matter. I didn't know about Adam. You're interviewing me today. I didn't know I would work with SEED, but with SEED, as you rightly put it, one of our policy agenda is to reach out, contextualize things. How best do we actually do this? And I'm a true believer in that one, that, I don't like fumbling. I don't want to moving all over the place. What are the issues in Malawi? As much as I'm a Malawian, what can SEED do as an organization? How can we get there? So reaching out is key to anybody that has interest in the colonization of global health. And I am aware that there are a lot of organizations that we should just put our acts together and move forward. And lastly, just to be on the lookout, what is out there that we can use as opportunities for entering into this agenda and doing something about it. I think we can. And now that we have started, colleagues like you, let us move together and make a difference. Thank you very much.
Thank you so much, Margaret. That was a wonderful note to end on. It's been incredible to hear Margaret's wealth of experience, lessons, and thoughts on health policy. 3 of my key takeaways are that to close the current gaps in health policies across African countries, we need to involve implementers and users from the beginning when they are being created and not at the end. We need to support communities during the implementation of the policies as well. And so countries should be supported when they are putting together their national development agendas, and they should have clear mechanisms on how they are going to engage donors so that the donors are not going to come and take over the development agenda creation process. Lastly, global health can only change if we as countries that were colonized take the lead and chart our own destinies. What are your key takeaways from this conversation? Share them with us on social media and don't forget to subscribe to the podcast.